Right, this is chapter 21, part B on the respiratory system. So in part A, we looked at primarily just the anatomical features of the respiratory system. This section, part B, we'll look at the physiology. So we said that one of the four main processes of the respiratory system was pulmonary ventilation, so just breathing. So we have to bring air in and out of the lungs. So pulmonary ventilation consists of two phases. So inspiration, where gases are going to flow into the lungs, and expiration, where gases exit the lungs. So to understand how the respiratory system works, how the lungs work, we have to look at the pressure relationships within that thoracic cavity. So we have to know a few different types of pressures involved in respiration. So the first one is atmospheric pressure. So this is just the pressure exerted by the air in the atmosphere. So at sea level, atmospheric pressure is 760 millimeters of mercury. So this is considered one atmosphere unit. So for our respiratory purposes, we consider atmospheric pressure to just be 0. So that's kind of our base standard point of reference. So the other pressures involved in the respiratory system that we look at when we talk about if they're a positive pressure or a negative pressure, that's relative to this 760 atmospheric pressure. So respiratory pressure is described relative to atmospheric pressure. So if it's a negative pressure, it would be less than 760. Positive would be higher than 760, and 0 respiratory pressure would be equal to atmospheric pressure at 760. Right. So one pressure involved in the respiratory function is the intrapulmonary pressure. So this is the pressure that's inside the alveoli or the air sac. So sometimes it's also referred to as the intra-alveolar pressure. So this pressure is going to fluctuate as we breathe, but it eventually will always equalize with atmospheric pressure to average out to 0. So intrapulmonary, intraalveolar pressure falls below atmospheric pressure during inhalation and then rises above it during exhalation. So during inhalation, we're at, say, 759, so that would be considered a negative pressure. Right. And during expiration, we're at 761, right, which would be a positive pressure. So if we average these two out, though, it's going to average to that 760, which is why we consider it to be 0. Intrapleural pressure is the pressure within the pleural cavity itself. Right? So this is also going to fluctuate as we breathe, but it's always going to be a negative pressure. Right? So usually it's about 4 millimeters of mercury less than our intrapulmonary pressure. Right? Or atmospheric pressure. So the reason we want intrapleural pressure to be negative, we want it to be less than the pressure in the lungs, is so that the lungs can expand. So if the pressure in the cavity were greater than the pressure in the lungs, then the lungs would be more constricted and wouldn't be able to fully expand and inflate with air. So looking at some forces of these intrapleural pressures. So there are two inward forces that are going to help promote lung collapse or expiration. So first would just be the lung's natural tendency to recoil. So remember we said they have a lot of elastic fibers on those alveoli, those air sacs. So the lungs will always want to try to snap back to that original size, that smaller size. And then another factor would be the surface tension of the alveolar fluid. So we'll talk a little bit more about this later on, but basically the surface tension is going to pull on the alveoli to try to reduce their size. Right, so the fluid in the alveolar sacs in the lungs, so think how water molecules tend to want to stick together, right? So to form surface tension of water and fluids. So with the water molecules wanting to kind of aggregate together, it's going to be an inward force, right? So it's going to try to decrease the size of the alveolar sac. So there is one outward force of intrapleural pressure that's going to want to enlarge or inflate the lung. So this would be the elasticity of the chest wall. So as we inhale, those muscles contract and are going to pull the thorax outward, right? So we can inflate the lungs. Right? So we said intrapleural was always a negative pressure. So this negative intrapleural pressure is going to be affected by those opposing forces. Um, but it's also going to be maintained by that adhesiveness between those pleural membranes. Remember, the pleural or the parietal pleural membrane lines the cavity wall, and then the visceral pleurae would line the surface of the lung. So these two membranes, the fluid within that membrane is also going to help to maintain that normal negative intrapleural pressure. Right, so your transpulmonary pressure is like the functional pressure that's going to keep the lung spaces open and keep them from collapsing. So it's basically just the difference between your intrapulmonary and your intrapleural. So the greater our transpulmonary pressure, the larger the lungs will be able to inflate. Right? But again, we have to maintain this negative pressure of the intrapleural to keep the lungs inflated. So again, if we had higher pressure within the cavity, that's going to kind of squeeze on the lungs and keep them from fully inflating and inhaling. So one type of maybe homeostatic imbalance we could see with the lungs. So if you have a pneumothorax, which would just be where something has punctured through that parietal pleura. So now the internal pleural cavity is exposed to atmospheric pressure. So the pressure inside the cavity is going to equalize with that atmospheric pressure. So that means our intrapleural pressure is no longer a negative pressure. Right? So that increase in the pressure, so we're going from say 756 to 760, is going to cause the lung to collapse and prevent it from fully inflating. So we said pulmonary ventilation consists of inspiration and expiration. So this is a mechanical process that's going to rely on volume changes, volume and pressure changes within this thoracic cavity. Right? So as we change the volume of the lungs, we're also going to change the pressure in the lungs. So these pressure changes are what's going to contribute to the flow of gases. So this pressure-volume relationship can be described by Boyle's law. So Boyle's law basically states that pressure and volume have an inverse relationship. Okay? So gases are always going to fill whatever container they're in. So if we have the same amount of gas, but we decrease the container size, right, then that's going to increase the pressure. Okay? So basically, if pressure goes up, then volume can go down, or vice versa. If volume goes up, then pressure would go down. So mathematically, this is the equation for Boyle's law to show this relationship. So just this example here, decreasing volume increases collisions and pressure. So say we have 5 molecules of a gas in a 1 liter container. Right? So these particles are bouncing around in this container. Right? So the pressure is at 100 millimeters of mercury. So if we were to decrease the size of the containers by half, so we go from 1 liter to half a liter, but we still have the same number of gas molecules. So now they're getting squeezed a bit more in the container, so that's going to increase our pressure to 200. Right? So if we decrease the volume by half, it's going to double the pressure. So inspiration is considered an active process because it's going to involve your inspiratory muscle. So it's going to involve activity of those muscles contracting. So the diaphragm and your external intercostal muscles of the ribs. So the diaphragm, when it contracts, is going to move inferiorly, move downward. So as a result, it's going to increase the volume of the thoracic cavity. Right? So Go back a slide. So imagine this is the diaphragm, right? This is the thoracic cavity. So when we inhale, the diaphragm is going to be pulled downward, right? So it would go this way. So that's going to decrease the pressure in the cavity and allow the lungs to fill with air. So the action of the intercostal muscles when they contract is also going to lift the rib cage up and out, which also contributes to an increase in that volume of the thoracic cavity. Right? So the more space we have in the thoracic cavity, the more space we have for our lungs to inflate. So as the thoracic cavity volume increases, the lungs are stretched as they're going to be pulled out with the thoracic cage. So during this step, the intrapulmonary pressure is going to drop to -1. So again, this would be the pressure within the alveoli. So because of the difference between our atmospheric and intrapulmonary pressure, right, the air is going to flow into the lungs down the pressure gradient, right? So just like basic diffusion of solutes, where we go from a high concentration to a low concentration, so the air is going to flow from the point of high pressure to low pressure. So now that intrapulmonary pressure is negative, so it's less than that 760. So the air is going to flow into the lungs where that lower pressure is. Okay, so expiration is more of a passive process. So instead of actively using energy to contract our muscles and our diaphragm, we're essentially just going to relax those muscles. So the natural recoil of the lungs and the thoracic cavity will do most of the work for us. Okay? So this is going to cause the volume in the thoracic cavity to decrease. Right? So remember Boyle's law, if volume decreases, then pressure is going to increase. So that's where we get intrapulmonary pressure rises to +1. Okay? So remember we said that intrapulmonary pressure always equalizes to 0 though. So during inhalation it's negative and expiration it becomes positive, but they're going to average out to 0. Okay? So now that the pressure inside the cavity is higher than atmospheric pressure. Again, so gas and air is going to diffuse from this point of higher pressure inside the lungs to lower pressure outside. Right? So the air is going to flow down the pressure gradient until we reach that equilibrium. Okay, so just putting inspiration and expiration together, right? So again, your inspiratory muscles and diaphragm will contract. So we're decreasing the pressure, right, within the alveoli, within the lungs, right? Because we are increasing the volume of the thoracic cavity. So the more volume we have in our chest cavity, the more the lungs can expand. So gases are going to flow passively from the point of high pressure in the atmosphere to low pressure inside the lungs. So this would be your active process. So expiration, we said, was passive. So we just relax all these muscles and the lungs will kind of naturally recoil, right, to their original shape, and it's going to decrease the volume, right? So chest cavity volume is going to get smaller. It's going to decrease, which increases the pressure inside the lungs. So the gases are going to diffuse down the pressure gradient from high pressure in the lungs to low pressure in the atmosphere. So this is just showing kind of relative changes of these different thoracic cavity pressures during inspiration and expiration. So again, intrapulmonary pressure is the pressure inside the lung. So it's going to decrease during inspiration, right, and increase during expiration. Okay, so intrapulmonary pressure is this pink graph. So during inspiration, right, it dips below 0, becomes a negative. During expiration, it increases and becomes positive. So, but it's going to equal out to 0. Okay? So an intrapulmonary pressure, pressure inside the lungs. So when we have a low pressure inside the lungs, that's going to allow them to fill with air. When we have an increased pressure, that's going to squeeze against those air sacs and push the air out. Intrapleural pressure, we said, was always a negative pressure, but it does still fluctuate within the negatives. It just becomes more negative as the chest wall expands during inspiration. Okay? So this would be pressure inside the chest cavity, right, the cavity wall. Right? So again, it makes sense that we want a low pressure during inspiration so that the lungs can expand. So if we had an increase in this pressure, it's going to kind of squeeze against the lungs and prevent them from fully inflating. And then, of course, your transpulmonary pressure, which is the difference between these two. So there are also some non-respiratory air movements in the respiratory system we should look at. So we move air in and out of the lungs in the respiratory system, but it doesn't necessarily contribute to gas exchange or breathing. But it still may have effects on our respiratory rhythm. And again, most of these are kind of reflexes, although some can be voluntary. So just some examples: coughing, sneezing, crying, laughing, hiccups, yawns. Right? So anything that we're still moving air through those structures, but not necessarily for ventilation purposes. So we have three physical factors to consider that are going to influence the ease of air passage and how much energy we require for this ventilation process. So some of these factors include airway resistance, the surface tension of the alveolar, and lung compliance. So airway resistance is basically the resistance that the air is going to encounter as it goes through these conducting zone structures. So usually when we get to the respiratory tree portion, it's pretty insignificant because the diameters in the first part of the conducting zone are pretty large. So like the trachea, the nasal cavity, the bronchi, the main bronchi, before we get into those smaller structures. So you see, when we only have maybe one branch, maybe just the trachea, it's going to have some of the least resistance. So as we progress and branch off into more and more divisions, we will slightly increase our resistance that we encounter. But then after we get to the smaller ones, we're increasing the total cross-sectional area, the total surface area. So resistance is then going to go back down until we get to the terminal bronchioles. Right? So the most resistance is going to occur in those medium-sized bronchi, where we go from one large trachea, one large tube, into those smaller branches. Right? So resistance is virtually going to disappear once we get to the terminal bronchioles, because this is where the gas diffusion is going to take over. So alveolar surface tension we mentioned a little bit earlier. So surface tension was just the tendency for water molecules to want to stick together. So they're kind of naturally attracted to one another. So it's going to draw those liquid molecules closer and reduce contact with dissimilar gas molecules. So again, the attractive force is going to be drawn kind of inward. So it's going to want to make this air sac smaller. Okay? Those fluid molecules are going to want to kind of huddle together in the middle. So water, which has very high surface tension, is going to coat the alveolar walls. And again, it's going to help the alveoli collapse or shrink and recoil. Okay. So the lungs produce a substance called surfactant, which is going to reduce the surface tension just enough so that the alveoli don't completely collapse in on themselves, because we want them to stay open somewhat, to allow air in. So again, surface tension, so like when you see a water strider bug walking on the surface of the water, so that's due to the surface tension. So these water molecules are sticking together strong enough to support the weight of the insect. Again, surfactant is kind of like a detergent-like, it's lipid-based protein. It's just going to help reduce that surface tension to prevent the alveoli from collapsing. And again, it was produced by those type 2 cells. So this is just an example of how surfactant can work. So without the surfactant, all of these water molecules are going to be kind of huddled together, which would shrink the overall size of our air sac. So the surfactant molecules kind of get in between different water molecules to prevent them from sticking together. So we reduce that surface tension just enough to keep the alveolar space open. So lung compliance would be measuring the change of lung volume that occurs with that change in transpulmonary pressure. So essentially how much stretch that lung tissue is capable of. So normally our lung tissue has pretty high compliance. So the lung tissue is very stretchy, distensible, has a lot of those elastic fibers, and the surfactant is going to also help keep those lung spaces open. So the higher the lung compliance, right, so the more compliant they are, the more cooperative your lungs are, the easier it'll be for them to expand and function. So if you have less compliance, you would have more restriction, right, shown here. So if they're not compliant, they're not very stretchy, we can't inflate or stretch the lungs to their full potential. So when we assess ventilation, we can look at several different respiratory volumes to assess an individual's respiratory status. So then we can also combine different respiratory volumes to calculate respiratory capacities, which can give even further information on somebody's kind of respiratory health. So generally these volumes and capacities would be abnormal in people that have pulmonary disorders. So we use what's called a spirometer to measure these respiratory volumes, and we'll get to do this in lab this semester, where you'll measure your own respiratory volumes and capacities. So the first respiratory volume is the tidal volume. So this is just the amount of air moved in and out of the lungs with just normal average breathing. Right? So on this graph, it's shown just by these small waves. So just normal rhythmic breathing, right, is the tidal volume. So it's averaged about 500 mils. Okay? The inspiratory reserve volume, or the IRV, is the amount of air that can be inspired forcibly beyond that tidal volume. So if we take a big deep breath, that would be your inspiratory reserve. So anything beyond a normal quiet breath would be the inspiratory reserve. So it has a much larger capacity, potential up to or average 3,100 mils. Expiratory reserve is the amount of air that can be forcibly exhaled from the lungs. So after a normal breath, how much extra air can we force out? So maybe if you're blowing out your birthday candle, right, you're going to blow as hard as you can, as much air as you can to get out. Right? So expiratory reserve averages about 1,200 mils. And then the residual volume is the amount of air that's always kind of left over in the lungs, and it's needed to keep those alveolar sacs open. So we can't 100% exhale all of the air in our lungs. We need to have a little bit left over for keeping those alveoli open. So you can see here where our graph doesn't dip down into this residual volume, because this amount is never going to really leave the lungs. So we can combine 2 or more of our respiratory volumes to calculate capacities. Right? So the difference between a volume and a capacity, so say if you have a 16-ounce water bottle, right, but you only have 8 ounces of water in your bottle. So you would have a volume of 8 ounces of water and a volume of 8 ounces of air. So combine those two together would give you a capacity of the 16 ounces. So capacity is kind of how much it can hold. So your inspiratory capacity is the sum of the tidal volume plus your inspiratory reserve. So this is the total capacity, the total amount that you could potentially inspire or inhale. Functional residual capacity is the expiratory reserve volume plus the residual volume. So this is essentially how much air is left over in the lungs after a normal exhalation. So we have the little bit that we can forcibly expire, and then we have that residual volume that's always going to be in there. Right? But these are going to make up the functional residual capacity. The vital capacity is the sum of the inspiratory reserve, tidal volume, and expiratory reserve. So vital meaning it's important. So this is the total capacity of all the exchangeable or usable air. So when air moves in and out of the respiratory system, right, it's contributing to gas exchange. Okay? So how much air total do we have that can contribute to this process of gas exchange? And then finally, total lung capacity is the sum of all lung volume. So how much air total can the lungs hold, right? So this is also going to include that residual volume. So even though it doesn't contribute to gas exchange, it still makes up part of that total lung capacity because it's going to remain in the lungs, keeping them open. So again, just to summarize, we have our 4 respiratory volumes, tidal volume being just your normal quiet breathing, inspiratory reserve being how much you can forcefully inhale beyond normal breath. So say you take a deep breath before you dive into the pool. Expiratory reserve is how much air can be forcibly exhaled after a normal breath. Right? So if you blowing your birthday candles out, you're going to exhale and blow as hard as you can. And then the residual volume is the amount that's always going to be left over. So no matter how hard you try, you can never get 100% of all the air out of your lungs. So capacities are combinations of these volumes. So total lung capacity is combination of all 4. So how much air total can the lungs hold? Vital capacity are going to be combinations of these 3. So how much air do we have that contributes to gas exchange? How much important air do we have? Inspiratory capacity is how much the lungs can inspire. So how much can we inhale total? So our normal inhalation and beyond our normal, so our deep breaths. Functional residual capacity is your expiratory reserve and the residual volume. So how much air is left over in the lungs after a normal exhalation. So looking at dead space, so this would be any type of space in the respiratory tract that doesn't contribute to gas exchange. So anatomical dead space would be pretty much just the air that remains in the passageway. So when you inhale, right, there's still going to be some air in your nasal cavity, in your larynx, and your trachea that doesn't make it all the way to the alveoli. Right? Alveolar dead space would be non-functioning alveoli. So the air reaches to the alveolar sacs, but the alveoli are non-functioning, so they're not going to contribute to that gas exchange. So this could be due to collapse or obstruction or some type of lung disorder. So our total dead space would just be the sum of your anatomical plus alveolar dead space. Like we said, spirometers are how we measure pulmonary ventilation efficiency. So it's also going to allow us to distinguish between different types of pulmonary disorders. So one type would be an obstructive pulmonary disease. So this would lead to an increased airway resistance. Right? So example like bronchitis, so maybe some inflammation of the bronchi, but essentially it's going to prevent air from flowing out of the air sac. So ultimately the lungs and the alveoli become overinflated. So this could cause an increase in the total lung capacity, right, and the residual volumes. Restrictive diseases are going to prevent flow into the alveoli, right? So it's going to restrict the alveolar sacs from expanding. Okay? So some examples of these would be things like tuberculosis or fibrosis. So with these, it would be kind of the opposite. So total lung capacity, residual volumes would decrease because the lung expansion is compromised. So we're not able to inhale or take in as much air. So restrictive, we can't take in enough air. Obstructive, we can't exhale enough air. So we can use some pulmonary function tests to try to measure the rate of gas movement in the respiratory system. So one thing to look at would be a forced vital capacity. So this is just the amount of gas or air that can be expelled after taking a deep breath. Your forced expiratory volume is similar to this, but only during a specific time interval, so maybe the first second. So generally, healthy individuals can expel about 80% of their functional vital capacity within the first second. So if someone has an obstructive disease, it's going to, again, prevent air from leaving the lungs. So they would be unable to reach this 80% in the first second. So it might take them a little longer to exhale 80% of their air. Okay. So looking at gas exchange, which is the ultimate function of the respiratory system, so there's two areas where gas exchange occurs. Right? So we have gas exchange between the blood and the lungs with external respiration, and we have gas exchange between the blood and the tissues with internal respiration. But both of these processes are subject to the same kind of properties of gas and composition of the alveolar gases and fluids. So we already talked about Boyle's law, so how pressure and volume are related, inversely related. So another gas law to look at is Dalton's law. So Dalton's law is the law of partial pressures. So Dalton's law just states that the total pressure exerted by a mixture of gases is going to be equal to the sum of pressures exerted by each gas. So a partial pressure is just how much pressure is exerted by each gas in a mixture. Right? So it's generally going to be proportional to its percentage in the mixture. Okay? So here in this example, so we have a combination of gas A and gas B. Right? So the total pressure exerted by this mixture is 4 atmospheres. Right? So gas A is going to exert a pressure of 1 atmosphere. Gas B exerts a pressure of 3. So if we just combine these two, that gives us 4. Okay. So another good example, so atmospheric pressure we said was 760 millimeters of mercury, but our atmosphere isn't 100% oxygen, right? So there are other gases in the atmosphere, primarily nitrogen. So let's say nitrogen makes up 78.6% of the atmosphere, right? And oxygen makes up 20.9%. So the partial pressure of nitrogen would be the 78.6% of our total 760. So 78.6% of 760 is 597, and 20.9% of 760 is 159. So if we were to combine these two, they would give us our 760. Another important gas law to look at is Henry's law. So Henry's law states that for gases to mix in contact with liquids, that they will dissolve in proportion to the partial pressure. Right? So the higher the partial pressure, right, the more soluble that gas would be. Right? So the amount of gas that dissolves in a liquid is going to depend on things like its solubility. So for instance, carbon dioxide is roughly 20 times more soluble in water than oxygen. Right? So this will come back into play in a little bit when we talk about gas exchange. Also temperature. So as temperature of a liquid rises, the solubility decreases. So if you have a soda that's been carbonated, right? So that's one reason why we use carbon dioxide in sodas, because it's very soluble in water. It dissolves very easily. But what happens if you leave a soda out in the open at room temperature, right? It's going to go flat, right? So the CO2 is going to kind of bubble out of the solution. So one example, kind of a clinical application of Henry's law, would be a hyperbaric chamber. Right? So within the hyperbaric chamber, the air pressure is going to be increased, and oxygen would be at 100%. Right? So that's going to kind of increase the solubility of the oxygen and how much oxygen is able to bind to the person's blood. So higher levels of oxygen in the blood would kind of speed up new tissue growth and assist in healing processes. So back to external respiration. So this would be your pulmonary gas exchange. So gas exchange of oxygen and carbon dioxide across this respiratory membrane. Okay? So this gas exchange is influenced by the partial pressures of the oxygen and carbon dioxide, as well as their solubilities. Right? Also the thickness and surface area of the membrane. So we said that the thinner the membrane, the faster and easier diffusion can occur. And then we'll look at ventilation-perfusion coupling, which just means that for the most efficient respiration, we need to match blood flow to our ventilation rate. So looking at partial pressure gradients and gas solubilities, right? So between the capillaries and the alveolus, we have steep partial pressure gradients, right, for oxygen. So the venous blood, so back to blue representing deoxygenated, so it has a low partial pressure of oxygen, it's only 40. Okay? The partial pressure of oxygen in the alveoli. So the alveoli have inflated with air, with fresh oxygen, right? So they're going to have a higher partial pressure, right? So these partial pressures are going to help drive that oxygen flow into the blood. So just like with diffusion, where we go from a high to low concentration, we're going from a high to low pressure. Right? So the oxygen is going to diffuse across the membrane into the blood. So then after external respiration, our new partial pressure for oxygen is 100. And in the alveoli, it would be 40. So they essentially are going to swap those partial pressures. So same thing with carbon dioxide, but if we notice the partial pressure gradient for CO2 is not as steep. So instead of having 40 to 100, having a difference of 60, we only have a difference of 5 or so, right? So we have we have a higher partial pressure of carbon dioxide in the veins, the venous blood at 45, where it's only 40 in the alveoli. So it's going to go from high to low. So we're going to go from the blood to the lungs, right? So we're pretty much exchanging oxygen for carbon dioxide. Right, so then we see the partial pressure of carbon dioxide has decreased in the blood. Okay? So even though the gradient isn't as steep as the oxygen, it's still going to diffuse in pretty much an equal amount. Because remember, CO2 we said was about 20 times more soluble in plasma than the alveolar fluid than oxygen. Okay, so this is just showing another kind of example of these partial pressure gradients and gas movement. So external respiration, so the air that you inspire, inhale, is going to have a higher amount of, or higher partial pressure of oxygen than in the alveoli. So CO2 is going to be decreased. So then we'll pretty much just swap oxygen for the CO2. Right, so as the blood leaves the tissues and enters the lungs, so partial pressure of the venous blood is lower than our air, right, or in the alveoli. So it's going to travel from the high number to the low number. Right, so same thing with carbon dioxide, but it's going to go the opposite direction. So it's going to go from the blood to the lungs. Right, so we're going from 45 to 40. Right, so here we said the thickness and surface area of the respiratory membrane also contributes to respiratory efficiency. So respiratory membranes are very thin, which is what we want. We want a thin tissue so the gases don't have to travel very far or use a lot of energy to cross that boundary. Alveoli also have a large total surface area, so we have these clusters and they're able to expand, so we can hold lots of air within these structures. And so your respiratory membrane, you have the alveolar wall is kind of fused and conjoined to the capillary wall in these spaces. And then we said we have to consider ventilation-perfusion coupling. So perfusion is just the blood flow that reaches the air sacs, so how much blood is reaching the lungs, and ventilation is how much air or how much gas is reaching those air sacs. So for optimal efficient gas exchange, we want to try to match the rates of ventilation and perfusion. So if we are ventilating faster than we're perfusing, then that means we're not exchanging as much gas as we could. So if we slow down our ventilation rate to match the perfusion, to give the blood enough time for that gas exchange to occur. So the pressures of oxygen can help influence perfusion by changing the arterial diameters, and pressures of carbon dioxide can influence ventilation by changing our bronchial diameter. So looking at the influence of the pressure of oxygen on perfusion, so changes in oxygen levels in the alveoli are going to cause changes in diameters of those arterioles. So if alveolar oxygen is high, then the blood vessels will dilate. So if we have a lot of oxygen in the lungs, then we need, or in the blood vessels, then we need to deliver more blood to that tissue. And vice versa, if our oxygen is low, then the arterioles will constrict. So opposite mechanism would be seen in systemic arterioles. So generally everything is backwards in the pulmonary system. So normal systemic arterioles would dilate when oxygen is low and constrict when it's high. So think if you're exercising, your skeletal muscles have an increased demand for oxygen. So we would dilate those blood vessels to increase the volume of blood delivered to those tissues. But with the pulmonary system, if oxygen becomes elevated, we're going to dilate the vessels to increase the blood flow. And then vice versa, if we have reduced oxygen, so we need more oxygen in the blood, we'll constrict the blood vessels to slow down the blood flow to give it more time to undergo the gas exchange. And then influence on oxygen on perfusion again. So changes in that pressure of oxygen in the alveoli can cause changes in diameters, CO2. It should be pressure of CO2. Changes in diameters of the bronchioles. So if CO2 is elevated, the bronchioles will dilate, so we increase the airflow. Vice versa, if CO2 is low, the bronchioles will constrict, right? So this would allow for more rapid elimination of the CO2. So just to slow it down to give the gas exchange more time to occur. So if the blood or the gases just pass through very quickly, then we might not get the most efficient or the maximum gas exchange. Right? So we always want to try to match our airflow to the blood flow. Right? So we have the same amount of gas coming in as we have blood to carry that gas. Right? So if we have too much gas and not enough blood, right, or too much blood and not enough gas, then we could run into some issues. Okay. So just another example of this ventilation-perfusion coupling. So if ventilation is less than perfusion, that's going to cause carbon dioxide to build up and oxygen to decrease. So to regulate, we would change the arterial diameter. So we'll constrict the alveoli to slow down the constrict the arteriole serving the alveoli to slow down the blood flow, right? So we have a decreased ventilation, so we also need to decrease our perfusion. So we need to slow down the blood flow going through the alveoli to give it more time to exchange those gases. Vice versa, if ventilation is greater than perfusion, right, so then we need to increase our perfusion. We need to increase the blood flow to that area. Okay, so we have increased gases, but we don't have enough blood to exchange those gases. So we'll dilate the blood vessels. Right, so we match the blood flow to our ventilation rate. Okay, so internal respiration is capillary gas exchange with the body tissues. So it's going to work similarly to external respirations, but the gradients are going to be reversed, right? So in the tissues, they would have the lower oxygen pressure. So say 40 in the tissue as opposed to 95 in the blood. So oxygen is going to diffuse from that high to low gradient. And same thing with carbon dioxide. So as the cells are undergoing respiration, the cells are doing their cell thing. They're going to be giving off CO2 that we need to dispose of. So CO2 is going to build up to about 45 in the tissues. But remember, it was lower in the blood. So it's going to diffuse out of the tissues and into the blood. Okay, so now our gradients have shifted. So this venous blood would be what returns to the heart and continues the process all over again with external respiration. So looking at some types of lung diseases, one of the most common classes would be COPD, so it's chronic obstructive pulmonary disease. So this could be something like emphysema or chronic bronchitis. But both share the same underlying key feature in that they have a decreased ability to force air out of the lungs. So as a result, most patients can develop hypoventilation, right, or an underactive ventilation, which can lead to things like respiratory acidosis and hypoxemia. So respiratory acidosis, so if you're not able to exhale adequately or enough air, then that CO2 starts to build up in the tissues in the blood. So CO2 can be converted or stored as carbonic acid in the blood. So that can become or make the blood and tissues become more acidic. It can also decrease the amount of oxygen delivered to the tissues and lead to this hypoxemia, so low oxygen. So just some characteristics of these two. So with chronic bronchitis, remember itis means inflammation, so it's kind of a continual irritation and inflammation of the bronchi. So it could be caused from things like smoking or air pollution, but ultimately it's going to cause excess mucus production. So as those bronchial cells keep getting irritated and inflamed, they're going to try to produce more mucus to try to soothe themselves. Right? So you'll have kind of a chronic cough as well, and cough up maybe a lot of phlegm and mucus. But ultimately you have that airway obstruction, so the air can't exit the lungs. It's kind of stuck in the lungs. Emphysema is a destruction of the alveolar wall. So all of those elastin fibers that allow the lungs to kind of recoil and snap back to their original size, they're going to lose a lot of that elasticity. So kind of the air sacs, the alveoli become kind of distended or flabby. So ultimately both, like I said, airway obstruction, dyspnea is just difficulty breathing. So we can have buildup of carbon dioxide, cause respiratory acidosis, and have underactive ventilation. Asthma is sometimes classified as COPD, but it's not technically because it's not chronic. It's more kind of an acute, rapid onset reaction. So has similar effects though. So you'll have some coughing, difficulty breathing, chest tightness, and inflammation of these airways and bronchospasms. So this is more of an immune response caused by release of some of those chemical alarms, chemical messengers of the immune system that are going to trigger just some inflammation. So they'll also produce a lot of inflammatory exudate, which is kind of fluid and excess mucus. This is also going to contribute to the obstruction of these air passageways. Tuberculosis is another type of respiratory disorder, but this one is caused by an infectious bacterium called Mycobacterium tuberculosis. So symptoms include things like fever, night sweats, weight loss, coughing, coughing up blood. So essentially these bacteria form what are called tubercles, or little nodules within the lung. So then when the person coughs, they cough up these encapsulated bacteria that can then spread to the next person. But because it is bacterial, it can be treated. But it's a very rough, long 12-month course of antibiotics, and they are starting to become more antibiotic resistant strains. And then finally, lung cancer. So lung cancer is the leading cause of cancer deaths in North America, and virtually all cases are a result of smoking. Right? So smoking is the leading cause of lung cancer. So another reason, like when we talked about, smoking inhibits those cilia. It kind of paralyzes the cilia in the respiratory tract. So all of that debris, that tar, all that nastiness just kind of is stuck in the lungs, and they're not able to clean themselves out. So generally, if someone stops smoking before cancer develops, it drastically reduces their chance of developing lung cancer, because the lungs will eventually clean and try to repair themselves. So it may take several years before their cancer risk goes down to that of a non-smoker. The three most common types of lung cancer: adenocarcinoma, about 40% of cases, it's going to originate in those peripheral lung areas. So places like the bronchi and the alveolar cells. Squamous cell carcinoma arises from the epithelium. So in the bronchi, remember we said the epithelia changes from that pseudostratified we saw in the upper respiratory tract to a more squamous epithelia. And then small cell carcinoma is going to affect the lymphocyte-like cells that originate in those primary bronchi, and subsequently will metastasize. So we had some immune cells in the respiratory tract to kind of prevent infections from taking hold or pathogens from gaining entry to the body. Well, sometimes these cells can become cancerous. So treatment for lung cancer, early detection is the key to survival. So as long as it hasn't metastasized or spread, it is generally treated with just surgical removal. Right? So if it has spread and metastasized, then it would require more invasive treatments like radiation and chemotherapy.